Bismillahirrahmanirrahim. Our lecture today is about liver transplantation. My name is Mohammed Charan. I'm an assistant professor of hepatobiliary surgery, Faculty of Medicine at Alexandria University. First of all, we have to know the anatomy of the liver. As we all know that there is two anatomical big lobes of the liver, right lobe and the left lobe, divided by an imaginary line, which is the Cantley line. The Cantley line is an imaginary line dividing the liver into a right lobe and a left lobe. This line is between the gallbladder bed and the inferior vena cava. The undersurface of the liver there is an H shape. This H shape this H shape is about the porta hepatis horizontal line, and a gallbladder bed, the umbilical fissure, the fissure for the inferior vena cava, and fissure for ligamentum venosus. The liver is divided also surgically into 8 anatomical segments. The left lobe is a 4 segment and the right lobe is 4 segment. Depending on that, each segment is supplied by hepatic artery and the portal vein and drained by biliary bile duct and also drained by hepatic vein. The arterial supply is coming from the aorta, giving the celiac trunk giving the splenic artery, then giving the left gastric artery, then passing as a common hepatic artery. This common hepatic artery giving the gastroduodenal artery, then it will be the proper hepatic artery which pass in the free border of the lesser omentum with the portal vein and the hepatic artery, entering in the liver, which is subdivided into the right hepatic artery supplying the right hepatic lobe and the left hepatic artery supplying the left hepatic lobe, and inside of the liver is subdivided to supply each coinode segment. This was the normal, that the celiac trunk giving the hepatic artery which divided into right and left lobe, which is the commonest. There is variability of this arterial anatomy, that the left hepatic artery can be an accessory hepatic artery from the left gastric, or the right hepatic artery coming from the superior mesenteric, or each the right hepatic artery coming from superior mesenteric and the left hepatic artery coming from the left gastric, or even all the proper hepatic artery coming from superior mesenteric. For the portal venous anatomy, the portal vein is, as we all know, that it is formed by the fusion between the splenic vein and the superior mesenteric vein behind the neck of the pancreas, and it passes with in the free border of the lesser omentum with the hepatic artery and the portal vein, and it's subdivided inside of the liver into left portal vein supplying left lobe and the right portal vein supplying the right lobe, and inside of the liver each portal vein is subdivided to supply each coinode segment. Also, there is variability in the portal vein. There is inflow and there is outflow of the liver. The inflow by the portal vein and hepatic artery, and the outflow by the hepatic veins. That we have 3 main hepatic vein: the right hepatic vein, and the middle hepatic vein, and the left hepatic vein. The left hepatic vein draining mainly segment 2 and 3, and the middle hepatic veins draining mainly segment 4, A and B, 5 and 8, and the right hepatic vein draining segment 5, 6, 7 and 8. The biliary drainage, we have the left bile duct and the right bile duct. The left bile duct draining the left hepatic lobe, and the right bile duct draining the right hepatic lobe. The right hepatic duct is divided into right anterior draining segment 5 and 8, and the right posterior draining segment 6 and 7, while the left hepatic duct is draining segment 2 and 3 and 4 and part of the segment 1. So there is nomenclature for the resection of the liver. So if we say that we are doing right hepatectomy, that we agreed that we have to remove segment 5, 6, 7, and 8. If we say left hepatectomy, that means that we remove segment 1, 2, 3, 4 segment. If we if we said extended right hepatectomy, that we remove segment all the right lobe and segment 4, for example. If we said extended left hepatectomy, if we remove segment all the left hepatic lobe and an added segment either 5 or 8. If we say that we do segmentectomy and we name a segment like segmentectomy 4, that means that we remove segment 4 only, or segmentectomy 3, we remove segment 3 only. Going back to our lecture, which is liver transplant. So the means of liver transplant that we have a donor and a recipient. The recipient is sick and is in need of a new liver. This new liver will be implanted inside of his body to solve his problem. So the recipient is a sick person, and there is some indications for this sick person. So who is the recipient? The recipient is either chronic liver failure, acute liver failure, or liver tumor, or metabolic liver disease. Including the chronic liver failure, either alcoholic liver disease, primary biliary cirrhosis, biliary atresia in newborn, post-hepatic cirrhosis, which is the commonest in Egypt and worldwide, autoimmune chronic hepatitis, and primary sclerosing cholangitis, and veno-occlusive disease like Budd-Chiari syndrome. For the acute liver failure, either due to paracetamol toxicity or viral hepatitis. For metabolic liver disease, alpha-1 antitrypsin deficiency, hemochromatosis, Wilson disease, Gaucher disease, and glycogen storage disease. For the liver tumor, we have not all patients with liver tumor can be subjected to transplantation as a solution. To reach a good prognosis and good outcome of the transplantation, if we offer it for the liver tumor patient, it is only indicated for HCC, and there is special selection criteria that we have to offer it to the HCC patient. We call it Milan criteria. The Milan criteria is the patient included the patient with single nodule 5 centimeter or less, or 3 nodule 3 centimeter or less. This Milan criteria is we agreed. It is agreed that the Milan criteria giving the good prognosis, and we selected the patient with HCC within the Milan criteria for transplantation. There is also two other criteria. It's called Bismuth criteria, University of California, San Francisco, which is either less than Milan and more than Milan. For the patient with hepatitis C patient, which is the commonest, and it's like an epidemic, so the HCV infection is a sequelae of either liver failure, liver cirrhosis, or HCC. So the sequelae of HCV either to go through cirrhosis, and this cirrhosis can end with liver failure, or this cirrhosis can be a risk factor for HCC, and also the treatment can be with a liver transplantation, either by liver failure or HCC. Can the treatment be by liver transplantation? For the contraindication, we have either advanced cardiopulmonary disease, severe irreversible pulmonary hypertension, hypotension on vasopressor, recent intracranial hemorrhage, uncontrolled sepsis, extrahepatic malignancy, active substance abuse. Also, if HCC beyond the selection criteria, which is Milan, HIV person, extreme of age above 70, cholangiocarcinoma, and liver secondaries also included in the contraindication. For the types of liver transplantation, we have either a deceased donor liver transplantation or living donor liver transplantation. As I've said, that the liver transplant, we have a donor and recipient. If the donor is a cadaver, we call it a deceased donor liver transplantation. So the donor is cadaveric in the deceased donor, which is the commonest done worldwide, not in Egypt, but worldwide, using the whole liver. We took the whole liver from a cadaver, and we remove the liver from a recipient, and we implant the whole liver from a cadaver, and to be implanted in the recipient patient. So we can call it also orthotopic. This deceased donor liver transplantation is divided into either a name cadaveric liver transplant, or split liver transplant, or auxiliary liver transplant. Cadaveric liver transplant, that we took the whole liver from a person, from a donor, and we implanted to the recipient. The split liver transplant, that means that we took the whole liver and we split it into two halves, one left lobe and one right lobe, and these two lobe, one will be implanted in two recipients. While auxiliary liver transplant, which is not done nowadays, it means that we have to take the whole liver and we implanted added to the recipient liver, which was not removed. The living donor liver transplant, the donor is a living person. We took a part of his liver, mostly the right lobe in the adult and the left lobe in the pediatric patient, depending on the concept of liver regeneration. If we took, of course, we have to take the part of the liver, which call it the graft, from the donor. It should be a normal liver. So we have there is a concept of liver regeneration if the liver structure is good, so the liver regeneration can happen. So the living donor liver transplant is divided into an adult living donor liver transplant using the right lobe and a pediatric living donor liver transplant using the left lobe. This work is not a one-man show. It is a teamwork, including the surgeon, hepatologist, anesthesiologist, ICU, nursing, and pharmacologist, and pathologist, and psychiatrist, and cardiologist. It includes all the teamwork to add for the success of the procedure. There should be an evaluation for the recipient and the donor. So for the recipient, we have to evaluate the etiology of liver disease, the severity of the condition of the liver, general condition of the patient, medical and psychosocial aspect of the patient. So for the assessment of the etiology of liver disease and the severity of liver disease, we can use the Child-Turcotte-Pouse scoring or the MELD score. The Child-Turcotte-Pouse scoring, there is some items that have to be fulfilled. It's like encephalopathy, ascites, bilirubin, albumin, and PT or INR, and we select through this table the points. For example, there is encephalopathy grade 1 to 2, it will take 2 points. Ascites, there is no ascites, we take 1. Bilirubin is above 3, we take 3. And we calculate these points. If the calculation between 5 to 6 points, we call the child A, which is compensated liver condition. If it is between 7 and 9, it is child B. If it is above 9, it's child C, which is decompensated liver disease. The MELD score cannot be, it is an algorithm and cannot be studied. It is only by a calculator in a smart phone and smart machines. So it includes a calculation of the creatinine, bilirubin, and INR. And this MELD score is abbreviation of model of end-stage liver disease, and it traces the prognosis of if we left the patient, the 3-month mortality and prognosis of the patient with end-stage liver disease if left without treatment. So it can trace the severity of liver condition. So the patient can be listed as an urgent for liver transplant. So as I've said, it showed the prediction of 3-month mortality based on the MELD score. If it is high MELD score, the mortality rate will be high. If it is low MELD score, the mortality rate will be low. So the minimum listing criteria, if we have child B or C, so the decompensated liver disease, or child A with a condition like complication of portal hypertension that interfere with lifestyle, like encephalopathy, recurrent variceal bleeding, or bacterial peritonitis. Preoperative assessment of donor and recipient to include all laboratory profile, lab workup, liver function test, hepatitis profile, virology and renal function test, and cardiology assessment, and chest X-ray and CT chest, ultrasound and Doppler, triphasic CT, MRI, CT angiography, and venography and portography to trace the anatomy of the hepatic artery and the portal vein and the hepatic vein. And for the criteria of ideal donor, if we have these are the criteria for ideal donor, we have to select the donor through it. So the age should be between 18 and 45 with compatible blood group. There is no hepatitis B or C or bilharziasis, no chronic disease or illness, no upper abdominal surgery, should not be obese, so the BMI should be less than 30 kilogram per meter square, and should be related to the recipient. There should not be financial background or financial benefit, and the donor should be willing to donate. We mean that there is no coercion, no force, should not be forced against his will, and no financial benefit. These are the criteria for ideal donor. These are example of triphasic CT, as you can say, the cirrhotic liver with ascites, and this is arterial phase, and this is the portal CT portography. You can see the portal vein, and CT angiography, you can see the hepatic artery. This is the CT venography, you can see the hepatic veins. Also, this is a CT angiography, and this is CT angiography. You can see the anomaly that the hepatic artery coming, right hepatic artery comes from superior mesenteric, and CT portography, you can see here the portal vein with esophageal varices. The outcome, there are good outcome in cases of cadaveric liver transplant, and if there is no complication. So the survival is good if the indication and the selection of patient through patient and donor were good. So there should be some equipment like C-arm. This is the C-arm. Through it we can do intraoperative cholangiography to trace the bile ducts before cutting the bile duct. And there should be an intraoperative ultrasound, ergo beam coagulator, rapid infusion pump, the C-arm, which is the X-ray, that can do the cholangiography, and cell saver. This cell saver is a machine that sucks the blood of the donor or recipient and filter it and reinfuse it again, so it can save the blood transfusion. We have to have a vascular instrument like bulldog and pot scissor and Statinsky clamps, as we are dealing with cutting and anastomosis of vessels. We have to have also, this is the cell saver, and this is the intraoperative ultrasound to secure that our transplant, our anastomosis are patent, and there is no kink and no narrowing or no stenosis. We should have two OR working at the same time in the living donor liver transplant, or working at different time in case of cadaveric liver transplant. So the step for recipient surgery, we have to start by anesthesia, and then positioning the patient like supine. Then we do sterilization and draping, and then we have to do the incision either by bilateral subcostal incision with midline incision, or a G type of incision, which is a midline incision with the right subcostal incision. The operation is divided into three phases. The first with dissection of recipient liver and total hepatectomy, then anhepatic phase and implantation of a donor liver, then post-revascularization phase and biliary reconstruction. So this is the incision. This is the example of a patient subjected to liver transplant. This is the recipient. This patient, we should secure hemostasis for him by doing good hemostasis of the abdominal wall and ligation of the collateral, and we can put a drap to the abdominal wall. Then we have to expose the liver by a self-retaining retractor. So there is no hepatic surgery with this kind of retractor for good exposure. Then we have to start by total hepatectomy, which entail mobilization of the liver and tackling of the hilum of the liver by identification, ligation, and cutting of the hepatic artery and the portal vein and the bile duct. Then also have to dissect and ligate and cut the hepatic veins. So after identification and cutting all the structure, we can do successfully total hepatectomy. So the whole liver will be removed, and the patient will be in anhepatic phase without the liver. This is the IVC, and these are Statinsky clamp on the hepatic veins, and these are Statinsky clamp on the portal vein, and bulldog on the hepatic artery and the bile ducts, waiting for the graft, which is a piece of liver which will be implanted in the recipient. This is the picture of the recipient without the liver. We call it anhepatic phase. This is the inferior vena cava and the hepatic veins waiting for anastomosis, hepatic artery waiting for anastomosis, portal vein and biliary bile ducts waiting for anastomosis and waiting for the graft. What kind of graft we can implant? We can implant either segment 2 and 3, which is called left lateral segment. This mostly in the pediatric age group, or the whole left lobe, including segment 1, 2, 3, and 4, and or we can implant the right lobe, usually in the adult, which is the whole right lobe, and each graft has a portal vein branch and a hepatic artery branch and a bile duct branch and a hepatic vein. These structures should be anastomosed with the recipient counterpart. And this, the anastomosis, we started the anastomosis by the hepatic vein first, then the portal vein second, then the hepatic artery third, and lastly, the bile duct can be anastomosed. So there will be, in case of living donor liver transplant, there is a hepatectomy operation that should be done for the donor. This hepatectomy operation, it's like the normal hepatectomy, but we have to take care of the graft that we have to resect, because this graft will belong to the recipient and will be implanted to the recipient, should be intact. So in the donor we do the right hepatectomy, and the right hepatectomy, the right hepatic lobe will be transferred to the back table and in the preservative, and this preservative either HTK solution, UW solution, and with ice, and the back table will receive the graft, which is the right lobe, and will be perfused with the preservative to wash out all the residual and all blood clots, and to be ready for transplant, or ready for implantation. Also, the back table procedure have to revise the anatomy, all the hepatic vein and the bile ducts present, and if there is any procedure we can add. Then the example, the procedure can add, we can do elongation of the hepatic vein, for example. Also, the biliary anatomy of the donor graft is very important to be known, either preoperative or intraoperative, because this will add of the difficulty of the procedure. Because if we had a different anatomy or anomaly like this, if we cut through the right lobe for right hepatectomy of the donor, so the graft will have two bile ducts away from each other or near to each other. This is an example of biliary reconstruction. So if we have normal anatomy, we cut through the right lobe in the donor, we have only single opening of the bile ducts. If we have an anomaly of the bile ducts, where the right hepatic duct is divided into two, so if we cut through this, we have two bile ducts that have to be anastomosed, both of them. If we have a different anatomy, that anomaly of the bile duct that have the right hepatic duct, right posterior bile duct coming from the left, if we cut through this in the donor, we have two bile ducts that have to be we have to anastomose two bile ducts, and this is very important because we have to avoid complication that can happen post-operatively. So this is an example of the donor with trifurcated bile duct. That means that we have three bile ducts. This is an intraoperative cholangiography that was done for the donor. So before cutting, we can know that we through the cut we can be faced with a two bile duct that have to be anastomosed, both of them. Also, this trifurcation can happen in the portal vein, and the same manner we have to take care for this kind of anastomosis. As I've said to you, we started by implantation in case of left lobe. We start on implantation by the hepatic vein, then the portal vein, then the hepatic artery, then the bile ducts, and the same manner the right lobe, the portal vein, then the hepatic vein, the portal vein, hepatic artery, and the bile duct. The bile duct either by hepatic jejunostomy or end-to-end anastomosis with a T-tube as a stent. This is a real-life picture of anastomosis of the hepatic vein, and then the portal vein anastomosis, then the hepatic artery that can be anastomosed either by the loop, by magnifying loop, or by my microscope. Then the bile ducts, and this is the hepatic artery anastomosed, and we can, at the end of the bile duct, the hepatic artery anastomosis, we have to do Doppler to be sure that the hepatic artery is patent and there is no narrowing, no clots, which is very important for the survival of the graft. At the end, we have to do biliary anastomosis, either hepatic jejunostomy or end-to-end anastomosis with a T-tube. For the post-operative complication, as we are doing vascular complication, we can be faced with bleeding or thrombosis of either hepatic artery or portal vein, or stenosis either for the hepatic artery or portal vein. We can, as the patient will receive immunosuppressant from day one, he can be subjected to infection. The bile duct biliary anastomotic complication we call the Achilles tendon, which is the commonest complication in cases of for liver transplantation, like leak, stricture, and biloma of the bile ducts. Graft rejection, also this kind of complication. Small for size syndrome, if we transplanted a small size of the graft for not compatible with the size of the recipient, so the patient be subjected to liver decompensation, and the solution will be retransplant. Primary graft non-function is another complication, and other extrahepatic complication like heart and kidney failure or pulmonary embolism. Post-operative immunosuppression is a combination of drug. We combine some drugs from the start of immediately after the operation. Why? To combine the drug to limit the toxicity of each drug and to allow flexibility in tailoring treatment for patient and indication. We can combine the steroid and antiproliferative drug like azathioprine and calcineurin inhibitor like cyclosporin. The common combination prednisolone, azathioprine, and tacrolimus. We have to reach a certain therapeutic level to reach the therapeutic level to allow the acceptance of the graft and to avoid rejection. The post-operative care, both patient will be transferred to the ICU. The recipient will be transferred to isolation room, while the donor in the normal ICU will rest in the ICU for at least 24 to 48 hours, while the recipient will rest in the isolation room until we exclude that the patient have any complication. The aim of the stay in the ICU of the patient for monitoring and stabilization of major organ like the heart and lung and kidney function and liver function, and evaluation of the graft function by the lab workout, by the radiology, and we have to achieve adequate immunosuppression inside of the ICU, and also detect and monitor and treat any complication that might happen to the immediately after transplant. That finally I have to small talk about small for size. It can be seen in a patient offered a small size liver in comparison to the weight of the recipient. So there should be a calculation that should be done before the surgery, considering the size of the graft calculated by the CT, side of the graft of the donor calculated by the CT, and should be weight and compared by a ratio to the weight of the recipient. So there should not be below 0.8. This is called graft recipient weight ratio. So if this can happen, if it happened that we offered a small size of the graft in comparison to the weight of the recipient, we call it small for SAS syndrome, and this sequelae will lead to liver failure and graft dysfunction, and the treatment will be retransplantation. Thank you for attention, and don't hesitate to send me email if you have any question. Thank you.